everyone. Uh, Thank you for coming here today. Welcome to the Center for Community Solutions' latest Medicaid Institute, this time focusing on collaboration in value-based care. My name is Lauren Anthus, and I'm a visiting fellow for value-based care at Community Solutions, and I'll be introducing our topic and our panel. I like to think that one of the reasons Community Solutions has been around so long, in part, is because we try to take complex policy issues and break them down in ways that are more accessible. Today, we hope to do just that. But first, let me start with a story. Recently, after I joined UVO Health, I was asked, what does UVO do? And I responded, we work with community health centers and other community-based organizations to enable value-based care. To me, as a wonk, this was a simple and straightforward response. But they responded, we're still doing that? Honestly, I've never really understood what that term even means, value-based care. I didn't take it personally. It made me realize that in a system as complex as US healthcare, we often get caught in our own self-fulfilling cycles of language and we lose the precision of meaning. Now, I could write a white paper talking about value-based care as the shift from mandatory fixed cost reimbursement to incentivize variable cost control through vertically integrated risk, but it doesn't really answer the questions that most people care about. Why is the US lagging other countries in key health indicators? Why is Ohio worse than the national average? Why are there such pronounced racial and economic disparities in maternal and infant health, in behavioral health, and in chronic diseases? You see, value-based care is an economic shift away from reimbursing providers for volume and instead tries to center prevention, wellness, and social risk as insurance risk. And now with Ohio's new managed care system, providers and payers are expected to do more to think comprehensively about the needs of the individuals they serve. Why? Because if Medicaid in Ohio is 4% of our state's GDP, and we are still seeing bad outcomes, policymakers are only going to grow more impatient before they start seeing cuts as a solution. So it's no longer acceptable in this new policy framework to be good at providing a diabetic amputation alone. Instead, it is imperative that partners collaborate and start answering the question, why do we have food apartheid in large swaths of our communities? Today, we're going to try to go from the abstract to the on the ground. We're going to move from the policy to the practical and provide a glimpse into what Ohio's new managed care system may mean for advocates, community-based organizations, and providers serving Ohio's Medicaid program. To do that, we've pulled together this panel of folks working on value-based care in New York and beyond. Let me introduce the participants in order of appearance. First, Dr. Andrei Ostrovsky. Dr. Ostrovsky is a managing partner at Social Innovation Ventures and former chief medical officer of the US Medicaid program, who invests in and advises companies, nonprofits, and artists dedicated to eliminating disparities. He also advises federal and state regulators on how to incorporate human-centered design into policymaking. Welcome, Doctor. Dr. Adam Aponte is the chief medical officer at East Harlem Council for Human Services Incorporated. A native of East Harlem, New York, he's a board-certified pediatrician with extensive experience in clinical work and healthcare leadership. After completing his medical education at Mount Sinai School of Medicine, he joined Children's Aid Society, where he worked with foster care populations and oversaw school-based health centers. Dr. Aponte served as the chair of pediatrics at North General Hospital, where he developed innovative programs to improve care for children in underserved communities. His commitment to addressing health disparities led him to work at federally qualified health centers, including 2 in East Harlem. He continues to advocate for diversity in healthcare through his involvement with mentoring in medicine. Welcome, Dr. Aponte. Zachariah Hennessy is Executive Vice President and Chief Strategy Officer at Public Health Solutions, leading the organization's community work in health insurance and benefits enrollment, food and nutrition, maternal and child health, sexual and reproductive health, tobacco control, COVID-19, and more. A tireless advocate who's grappled with some of New York's toughest health and social challenges over a 17-year career, he has secured investments to expand behavioral health, child development, and preventative healthcare in underserved communities. Welcome, Zach. Finally, Pantelis Chronopoulos, better known as PK, is the Vice President, Value-Based Payment Initiatives and Risk Adjustment, Fidelis Care in New York, where he's overseen the negotiation of hundreds of value-based payment contracts and, more recently, assumed responsibilities for all healthcare analytics. With his previous experience on the provider side, working at the Hospital for Special Surgery's Managed Care Contracting Department, PK offers a multi-layered perspective to managed care. Welcome, PK. We'll hear from each of our panelists for about 10 minutes, but this will be more of a dialogue, and they'll provide background on their organizations and their experiences in value-based care and collaboration. After they've concluded, we'll go into question and answer. So if you have questions, please put those in the chat, and we'll make sure to provide those to our moderator, Dr. Ostrovsky. We ask that you keep your questions in the form of a question, and we'll do our best to answer all the questions that are asked. With that, I'll now hand things over to our moderator, Dr. Ostrowski, to provide us with some level setting on the national policy landscape. Doctor, the floor is yours.
Lauren, thank you so much. I really appreciate you having me here. I'm excited to have our panelists here as well. Folks, we're going to try to have this be dynamic. I will keep an eye out on the questions as we go, so I'll try to pepper them in throughout. We will leave time at the end from 12:45 Eastern onward for Q&A. But if we can incorporate your questions in real time, I will do my best to do so. Having said that, I wanted to provide a little bit of a national context as well as a bit of an Ohio focused context on how the focus on Medicaid populations, the focus on managed care, and the focus on value-based payment is evolving. This is a very interesting time to be in health policy, to be innovating, both on the technology front and on the payer front. We have an administration which has wrapped up all of the cleaning up from the prior administration and has really gone into playing offense in a good way, in a productive way. We have seen really interesting guidance around managed care and access. We've seen really interesting guidance around justice-involved populations. We will be seeing guidance around pharmacy, and there's a universal theme around addressing social needs. To elaborate a little bit on those regulatory and sub-regulatory artifacts, we have just under a month ago seen a proposed rule around managed Medicaid. And what that rule has done or is proposing to do is pretty interesting. It doesn't provide a wholesale revamp of the managed Medicaid environment, but it does speak to some interesting themes around access, some interesting themes around medical loss ratios, and what I think is most exciting from an innovation perspective, in lieu of services. There's also some guidance around quality measurement and quality improvement that has important implications in Ohio and beyond. Briefly, the proposed rule speaks to requirements to broaden access. There are provisions in place to ensure that there's going to be kind of a secret shopper function to ensure access really is what managed care organizations are reporting it to be. There will be a more analytic approach to quantifying access and making sure that what consumers are feeling, not just what the papers say about access, is actually happening. There's also some guidance around state-directed payments. This gets a little bit wonky and doesn't directly impact value-based payment, but it is worth noting that there are some administrative innovations that are proposed in the rule that have implications for managed Medicaid, which in turn has implications for how Medicaid MCOs interact with provider networks trying to take risk. There's also guidance around medical loss ratio standards. In particular, there is increased scrutiny over managed care plans to require states to provide medical loss ratios for each plan. This wasn't universal previously and now is being codified to ensure that it's happening across all plans. So there's a level of accountability that has been increased with this proposed rule. I mentioned also in lieu of services, so there was sub-regulatory guidance. I believe it was CMCS informational bulletin that basically said, hey, we put out guidance back in 2016 about in lieu of services, and now we're going to broaden what in lieu of services can cover, as long as you also have an increased level of accountability. And for those folks that may not be familiar with in lieu of services, what it allows for is if a state Medicaid program has a fee schedule, and on that fee schedule, perhaps there isn't a particular technology or a particular service covered, but there is a comparable service that is on the fee schedule to, let's say, some kind of technology. So let's say if technology focuses on empowering consumers to thrive in their home instead of going into an institutional setting, if that technology has a comparable cost to, let's say, home care services, then that technology could be basically added to the fee schedule functionally through this in lieu of services mechanism. So this opens the door for a lot of really interesting service and technology innovation. And as long as states and managed care plans are held accountable and transparent about what they're actually including, in lieu of services can cover a very wide range of services and technologies. Finally, in this proposed managed care rule, there is increased emphasis around quality improvement. And as we have been hearing, and what we will actually be seeing in 2024, those Medicaid core set quality measures no longer an option. They are mandatory. That has pros and cons, but I think in the end it's a net positive. It's more of a focus on measurement-based care, and not just from a reporting perspective, but from the perspective of actually driving quality. And I think that's a very exciting development. Briefly, some of the other themes that are happening that I alluded to at the federal level, we've seen an increased flexibility around how Medicaid can pay for justice-involved populations. There was a state Medicaid director that came out earlier in the year that essentially opened the door for states like California to provide coverage for people that are in prison, and 60 to 90 days prior to their release, they can actually get coverage through Medicaid for healthcare services, creating a more facilitated transition out into the community, reducing recidivism, and improving the likelihood that we'll be able to actually close health equity gaps for these highly vulnerable patient populations. Two other items I mentioned, there's some pharmacy guidance that's coming out. This has a lot to do with value-based payment because it speaks or will be speaking to price transparency and advancing what has already been started around 2015 and then advanced since then, which is value-based payment for drugs. And that's a really interesting complement to value-based payment for services. And so transparency and value-based payment go hand in hand. So we'll be seeing some guidance around that. And finally, there is this attempt to unify all of the sub-regulatory guidance around social needs. I mentioned some of it addressed in the proposed rule around managed care. But one thing to note is CMCS, the National Medicaid Program, they are very backed up with 1115 demonstration proposals. And what they're trying to do is unclog that backlog by providing guidance that will enable states to get approval or request approval to address social needs through things like state plan amendments, 1915 waivers, and then, as mentioned, some of the in lieu of services that may not even need a state plan amendment. And so we'll be seeing some language from CMCS to that effect. So between the managed care, justice of all populations, value-based payment on drugs, and transparency, and this unified guidance around addressing social needs, we have a very robust federal backdrop to enable states like Ohio to advance value-based payment and do it in a way that's focused on quality measurement, quality improvement, and transparency. I mentioned Ohio, and I can't not address the pretty exciting work with the next gen Medicaid innovations that are happening. I'll be very blunt. Prior to this program, there wasn't a whole lot of clinical accountability in managed care in Ohio. I say this with all love for my friends in Ohio. And it's not just going from 5 to 7 managed care plans. It's going from basically being a fiduciary intermediary from the state to managed care to care provision, to managed care entities now are on the hook to the tune of $600 million quality withhold in order to do quality improvement and shift care towards value-based payment. That adds up to a few percentage points of revenue, which means basically their entire profit margin in some cases. So this is a big deal. I think it's a very productive development. It's going to be difficult for managed care plans, but in the end, I think patients will benefit, and providers have really, assuming they have the supports, providers have a really interesting opportunity to transition to value-based payment. One really interesting innovation that I don't think is really talked about in the media about next gen is 5% of profits from plans have to go back into communities. That's a big deal. There's a health affairs article that some of my colleagues from the American Board of Family Medicine and I published recently in March, highlighting outputs from 2 workshops we conducted in 2022, looking at designing a future state of addressing social risk through payment. One of the outputs from those workshops is investing in the infrastructure around community-based organizations. This provision of 5% of profits going back to the communities does just that. Essentially, community votes on how those profits are allocated to the community, and voila, we've got building up of infrastructure, which in and of itself is a really neat way for marginalized businesses to have an opportunity to grow. Briefly, I'll mention all drug benefits have been basically put under one PBM. There's a single credentialing entity for all MCOs. There's a single health IT hub. There's a lot of really interesting innovation happening. And all of that is a net benefit and accelerant to value-based payment. Now that we have this context, let's have the actual experts walk us through some of their experiences. And what we're going to do is we're going to start with Dr. Aponte, followed out by Zachariah, and then PK will round us off. So we'll have the FQ perspective, the CBO perspective, and the payer perspective. And I'll keep an eye out on the Q&A, and I'll try to pepper them in as we go. And with that, Dr. Aponte.
Great. Thank you, Dr. Ostrowski. That's a great context and great background. And thank you for folks joining us today. Happy to be joining you guys from New York City, East Harlem, New York, where I sit and run a FQAC. So for those of you who don't know, FQAC stands for Federally Qualified Health Center. We're a HRSA designated site. We serve communities of need. And there are about 1,600 FQACs across the country. And in East Harlem, we actually have 3 of them, which really speaks to the need, because HRSA normally would not allow 3 FQACs to operate in that area. But we have a high density population in East Harlem, New York, with a lot of needs. And, when you talk about health disparities and health inequities, everything you've heard of exists in our communities. So what we try to do, obviously, is to, do our best to provide primary preventive care services to our community in this fee-for-service model that, all exists. And while we, as a FQHC, we certainly have the opportunity to get some enhanced reimbursement rates through HRSA because they want to make sure that we are able to do the work that they want us to do. It's still not a great model to deliver care in today's world. When you think about issues that happen outside of the health system, the health center in particular, there's this term called social determinants of health. I don't really like that term. I'm a pediatrician. Determinants to me, words are very powerful. And when you say determinants, it denotes an inevitability of something that is going to happen no matter what. You have no choice now, is determined. I'm a kid from East Harlem. I grew up in this neighborhood, and I've done well despite these issues like food insecurities and poverty and crime rates and poor housing conditions. And while those things can influence your health, they don't necessarily determine them. And so I like the term influences much better. But how do we address those? Because those things are equally, if not more important, than the care that I provide in this health center. As a pediatrician, I can take great care of an asthmatic child in my office. I have great medications, I can do fine by them, but then I send them back out to the community and I can't address the issues that they face, like diesel fuel emissions, cockroaches, smoking, and all those other things that impact their health. So in order for us to really provide whole person care and take care of folks in a more holistic view, we got to be able to do things innovatively. Which was mentioned earlier. You cannot innovate in a fee-for-service model. You can't do those types of things that we want to do, like have care managers, do home visits, provide food to our patients. And so how do we do that if the only way I get reimbursed as a health center is by bringing people through my door and having a visit and getting paid for that visit? And so that's why it's very frustrating to us as FQHCs, this model. And, I've said this jokingly, but, fee-for-service is really dead. If it's not, we should kill it. Because the way to really do this is in a value-based contracting model. And that brings a challenge for FQHCs because these models, if you're familiar with them, they have what's called upside risk and downside risk associated with them. There's a risk to it, right? So we take a population of patients that we see for MCO, and we say, that patient population costs us $10 million or so to manage. We're telling the MCO, if we have better data and we're able to do things more innovatively, we can decrease that total cost of care. You guys will save money. And some of that savings we want to us, and we know there's some quality metrics. But to achieve that savings, I gotta be able to do things a little differently. right? And one of the things I talk about value-based contracting is care management is the key, right? I need folks that can engage my patients and help keep them out of emergency rooms, make sure that they connect with their primary care providers, make sure that they get transitions of care when they leave the inpatient to outpatient setting, make sure that they're taking their medications and understand how to take their medications, and not require them to come into my health center every single time to get that information or that education. Right. And what that also allows us to do is create capacity and access that was mentioned earlier, right? Access is a critical piece and making sure that people have access. And we're held to very high standards. We're highly regulated as a FQHC. And we're required, unlike commercial, that if a new patient comes to us, we got to see them within 4 weeks. Right? Otherwise, we get dinged in terms of our metrics and evaluations. And so how do I do that if I continue to see patients who have chronic conditions? Because trust me, every patient that walks to our door has at least 2 chronic conditions. And most of the time it's diabetes and hypertension in my adult population in particular. And so, if you're taking care of these patients with these chronic conditions, how do you make capacity for others if the only way you can care for them, quote unquote, right, is by seeing them within the health center and not being able to do things more innovatively through care management, through nurses calling our patients. And so finally, we've been able to get into that value-based contracting game, if you will, through innovative IPAs. And one was mentioned earlier, UVO is a very unique IPA that we actually joined recently. Their venture capital backed IPA, which is very interesting because they assume the risk for an organization like us, because HRSA does not allow us to play with their money. We cannot put their money at risk. And so we wouldn't be able to go into risk contracts without having a partner like UVO who has been able to raise capital and sort of assume that risk, allowing us to go into this value-based contracting model. And so we're very excited about entering into that. New York has been doing value-based contracting since about 2015. At one point, through DSRIP, which is a whole Medicaid redesign, a certain number of contracts were required to be in a value-based contract. But I think COVID really derailed that a little bit. And so the appetite for value-based contracting has sort of stabled off a little bit, but it is really the model in which we need to go into to really be innovative and do some of those really interesting things. Provide transportation, provide food, provide clothing. We have a diabetic patient who's homeless. Well, I think they're worried about where they're going to sleep more so than getting their diabetes medication, right? So how do I address that? How do I partner with community-based partners? And so that value-based contracting sort of arena allows us to really innovate much more so in that space. And let's do things a little differently, have patient navigators, all those sorts of things that really help us navigate this complicated healthcare system. And it's very complicated, way too complicated. And imagine serving a population that, English is a second language, not high literacy rates, not high school diploma rates, and all the other elements that they deal with. So for us, we're very excited to be a part of it. We really want to continue to push the dialogue across the country to really move towards that. Pays for the quality of the care that we provide, not the quantity of the care we provide. So I'll end on that note because I want to make sure we leave enough time for Q&A, but those are some salient points that I really want to hit upon.
That's terrific, Dr. Aponte. Thank you for that. I think that your reference to social influences of health as opposed to social determinants of health is such an important point. The other thing you mentioned, which I'd love to ask a quick question before we move on to our next speaker, we're pediatricians. We're literally born to care for people, especially for folks that can't advocate for themselves. Absolutely. Having said that, medicine is a business, and nonprofit or for-profit, the dollars have to come in order for care to sustainably be delivered. And I'm curious, with FQHCs and their relatively privileged daily rate that they get relative to other safety net providers that may not be an FQ, what is the threshold to say, we're going to go through the extra work to go and take financial risk and partner with a UVO or partner with some other entity that will help us take financial risk? Is there a certain threshold where you and your colleagues say, yeah, we're going to be able to really get rewarded financially way more if we go and take that financial risk? Is it a 1% increase in revenue? Is it a 40% increase or opportunity for 40% increase in revenue? Is there a particular threshold that has convinced you and your colleagues to say, yeah, let's try this thing?
Yeah, and thank you for that question. And you're quite right. I think people think of not-for-profits and they think they don't make profit. No margin, no mission, right? If we don't have, we have to make money, but not at the cost of
Right.
compromising care. I think that's really important. And so for us, any additional margin, whether it's 1%, 10%, 5%, we'll take it all because we operate in such tight margins that if we can make 1% margin is significant for an organization like ours. It can help us to afford other things that we can't currently afford. So for us, there's an upside to this no matter what, and that upside to us is what sort of draws us to it. And we're confident about the upside being even more significant because one of the things that I didn't mention is, and rightly, and something that we should really focus on is quality, right? Because the first thing, all these value-based contracting people should know, there's quality gateway to shared savings. You don't get that shared savings if you don't meet quality metrics. And what we've been able to do as a FQHC, in particular our FQHC, is really raise the bar on quality. And that was a big focus of mine coming into here about 3 years ago, that let's make sure that we provide the highest quality care possible, because with that quality, we're gonna have opportunities for value-based contracting. And some of these MCOs do, some quality incentive programs that we're able to tap into, but they're not as robust as value-based contracting. So when you have that strong of a quality performance, only going to be an upside to us, particularly when you have, again, that savior on the downside. Although we would take downside risk if we could, but HRSA doesn't let us, because we're confident in the quality and our ability to engage our patients and do a lot better than they are now in terms of like ER visits and unnecessary inpatient admissions.
Great. Thank you so much, Dr. Aponte. We, as medical providers, even in very robust FQs, and I also work in one, I'm here in DC at Mary Center, we really can't achieve the impacts that we achieve without our community partners. And I would love to hear from Zachariah about what your organization does and how community-based organizations partner with medical providers to help consumers meet their medical and non-medical needs, and certainly any other experiences you'd like to share with us, Zachariah.
Thank you so much, and it's great to be here today. And if you don't take anything else away from anything I say, you can just look at this sign here and take in that message, because really, I think sometimes what gets left out of the conversation are the experiences that people are having when they interact with healthcare and the social safety net. And I will do my best to try to describe the part of the landscape that is less talked about in this conversation of value-based care, which is the community-based resource landscape that we're now working to try to better integrate and leverage in healthcare. And my background is on both sides. I've worked for nonprofit community-based organizations, but also health systems. So Public Health Solutions is a nonprofit organization in New York City focused on health equity. And we go about it in 3 ways. We're a service provider across the 5 boroughs, providing food and nutrition, maternal and child health, sexual and reproductive health, access to benefits and health insurance, enrollment navigation, and tobacco-free housing and communities. Second, we are a contracting and management services organization, which means that whenever there's a complex public health initiative to roll out at scale, we serve as a master contractor for community-based organizations. So you can have one contract with us that includes hundreds of community-based organizations and of all different types of contracting types as well, including performance-based contracting. And so we're a vehicle for getting dollars to where they're most needed to make a difference in health equity to the small CBO that maybe would have difficulty with government contracting or healthcare contracting on their own. And then the third way is through our healthcare community partnerships work, which is what brings us here today, which is we're really working to build trustworthy and reliable pathways between healthcare systems, managed care organizations, and resources in the community that have the potential to positively influence health. So with that work, we operate a network called Whole U NYC. Whole U NYC includes about 400 community-based organizations, 120 of whom hold contracts through us with healthcare, managed care, to provide a range of services such as food, transportation, housing, legal immigration, benefits, low-cost healthcare. That network has essentially 3 established pathways by which people access the resources in our network. Healthcare referrals, so we have hospital and other healthcare provider partners who we're connected to via technology, and they make referrals directly to us. Health plan member outreach. So we have contracts with health plans whereby we reach out to certain segments of their membership that they consider to be at risk. I prefer to say at promise. And we also have a publicly facing portal because we're about health equity. And one of the main reasons why we've gotten involved in this movement is to ensure that whether or not you get access to meal, housing, et cetera, does not start to depend heavily on who is your provider or who is your plan. Otherwise, we're going in the wrong direction here. So we're very focused on chipping away at that wrong pocket problem, which is where health systems reap the financial benefits that are earned by community-based organizations in the public health system, including CBOs and FQHCs. I think the terms that we use are really important. When we talk about our work, you'll notice, using dehumanizing and industrial language when we talk about human lives is really at the heart of the problem that we have with trust in communities. It's why people don't trust healthcare. And I'm going to do my best to avoid using the terms like social care, a term that is bitter in my mouth because it really pathologizes poverty. And people don't understand their challenges that way. People don't understand their challenges as social. So I'll speak about how to better leverage and incorporate community resources into value-based healthcare. And when it comes to new Medicaid and Medicare policies developed to improve access to these resources, most of the conversation is very technocratic. In other words, what screening tool should we use? Where is the data going to live? How will interoperability work? What is the workforce and workflows? How best to incentivize things? And I'm not saying that's not important. It's very important. But as important when we're talking about meeting basic human needs and behavior change, both of which are important to achieve the impact on health outcomes and costs we intend with value-based care, the principles by which we implement the policy can be as important as the technical nuances or the nuts and bolts. So when we're talking about how Ohio decides to invest that 5%, here are 5 principles. 1, include the intended beneficiaries. Wait, where's my finger? Include the intended beneficiaries in the design, implementation, and evaluation of the model. They can tell us who should be asking them these questions, where and when is the best time to be asking these questions in our lives. How can you ask it in a way that's not stigmatizing or offensive? So that's principle 1. The second is invest in existing community-based resources. In other words, healthcare, please don't stand it up on your own. It's going to be more costly. You're expensive, okay? So direct those investments to community-based organizations who are able to much more efficiently and with better knowledge and years of expertise, put those dollars to work. But the business and operating models are different. So ensure that you're developing fee structures like we've done here in New York that work for community-based organizations. I'm watching the time. I have 2 more principles. The next is reduce administrative and compliance burden. So don't require replication where the evidence base is strong. Like you don't need to reprove that nutritious meals are going to help people with diabetes over and over again, and direct your dollars towards endless proof of concepts and demonstrations. And use creative strategies to mitigate that regulatory burden. To the greatest extent possible, we need to avoid imposing the Kafkaesque regulatory landscape of healthcare onto the human service sector, which, by the way, has its own siloed, fractured, Kafkaesque system that it's administering. So at Public Health Solutions, some of the ways we're organized as a hybrid HIPAA entity allow us to work with community-based organizations without imposing HIPAA on them when we can. And then finally, limit how much technology drives decision-making. Technology is critical supportive tissue, but it cannot discern the most important elements of what we need to be effective in, again, meeting basic human needs and behavior change, which is a person's priorities, willingness, ambivalence. And so our whole UNYC network, while it operates on a technology platform, requires a whole workforce of multilingual, culturally relevant community health workers to ensure people don't slip through the cracks and their real priorities are being met.
Zachariah, this is great. I'd love if you could maybe throw those 5 principles for us, or if you could direct us to where we could find them. That's fantastic. You mentioned something that made me bristle a little bit, and in empathy with how sad it is. You reference how there's like an industrializing language, right? This making healthcare, human services, almost like consultant speak. And I recall, and I just looked up this quote from a former chief medical officer of a national health plan. Don't worry, PK, it wasn't Centene. Centene wouldn't do this kind of stuff. But the physician said, prior auth was an automated industrialization of provider abrasion. Ooh, and initially he was kind of bragging about it. He's like, we invented that. I was like, okay, that's terrifying. And so I think it's scary that factory type of language is being applied to how we are trying to help people thrive. So I'm really glad you brought that up. And there are a handful of questions that have come in, but what I'll do is I'm going to save them until after PK's comments. And what a great segue of a plan that doesn't do that, and a plan that actually focuses on consumer centrism. PK, I'd love to learn from you from the payer perspective and how the kind of work that you all are doing.
Good afternoon, everybody. Proud member of the dark side here, apparently. So I'd like to give a different perspective, and I will do my best not to veer off into a rebuttal type of conversation. So let's just start with what does value-based payment mean for me, and overseeing all of our VBP arrangements in New York State, one of 33, don't quote me on that, or maybe 34, maybe 32, 17 markets. New York is one of the 4 largest. There's 7.5 million Medicaid beneficiaries in New York State. We have 2 million of them. So our VBP strategy in New York State is critical. And what it means to me is it assists me and my organization in just being a better organization. It puts accountability on both sides of the equation. And where we have always looked at the provider, the member, and the plan as the Trinity. We have recently expanded that to, I can't think of an equitably fancy word for, quadrilateral, but including community-based organizations in there, and creating that circle of communication to address all aspects of the individual's life. What I often stress, and it's a result of my analytical responsibilities as well, is that plans quite often inadvertently, unintentionally, perpetuate the disparities in health because we are dependent on data to make strategic decisions, as is every organization on this earth, whatever their specific slice of any industry is. And our data is a direct result of members that have access to care. I'm dependent on claims, up until very recently, solely dependent on claims. And with 2 million Medicaid lives, on average, we have 200 to 220,000 Medicaid lives that are considered non-users, meaning not a single service rendered in the last 12 months, not a single pharmacy script, not a single ED visit, nothing at all, no services at all. Add in a maintenance drug without a specialist visit, a chronic condition maintenance drug without a specialist visit to manage that condition, or add in an urgent care visit, a singular urgent care, or a singular ED visit, that number jumps up to over 350,000 members. So their needs are often disregarded because there's no evidence of them in our system or in the data that we pull from to understand where the needs are in the community. And just to put it into perspective, because I imagine most of the audience is Ohio, despite most of the speakers being from New York. Hamilton County is about 405 square miles large and has 4,400 residents. New York County, the city, one of the 5 boroughs, is 22 square miles and has over 8 million lives. So Fidelis is the only plan in New York State to operate in all 62 counties. So our strategies have to vary significantly, drastically, based on geography, based on demographics, based on needs. Where transportation is a huge issue and access to care is a huge issue in rural New York, it's less an issue in the city. In the city, it's housing, it's food insecurity, it's other issues. The other thing I often stress is, and despite the complexities and the challenges of an administrative burden on organizations like community-based organizations to record and store the data someplace. Without the data in our system, it doesn't exist. It doesn't exist in the eyes of New York State. And when we're talking Medicaid, New York State or any state sets the budget, sets the funding for which we have to make these investments in the community, to make these investments in community-based organizations. So it's critical that some solution exists where if you are a community-based organization doing the good work that you do, and there's no documentation because I recall a panel that I was a part of. I was a representative from a community-based organization, CMO from an IPA, and myself, and me and the CMO were going back and forth, and it was a strong but intelligent, thoughtful conversation. And the moderator, just to get the CEO of the food bank, the community-based organization, in on the conversation, kicked it to her, and she looked at us and she said, "That sounded all very smart. I'm just trying to feed people." And we often forget that that's really at the root of it, what it is. But that requires documentation because it requires funding. And my concern is when these 1115 waivers go live and plans are now, there's an influx of money and plans are making these referrals at volumes never before seen. The community-based organizations that are often supported by volunteers, supported by grant donations, they're going to be at capacity and they're not going to be able to continue to do the work. So the documentation, the reporting, the structure that is built beneath it will allow it to sustain beyond whatever the funding period is by New York or any other state. And a lot of that is made available and is made capable because of value-based payment. It puts the plan, the provider, and the community-based organization on the same side of the equation as a team to do what is most important for the individual's life in the total aspect of their lives. If you take, I often refer to the image of an iceberg, and the clinical needs of the individual is that piece of ice that's above the waterline, and everything else in their lives is below the waterline. And that often goes overlooked because we don't see it. I don't see it from a plan because it's not in my claims data. So how do we partner with the organizations in the community, with boots on the ground, with the connections, the human connections that exist, whether the community-based organization representatives or the physicians, they look the same, they speak the same language, they, I think 27 different languages in one county alone in New York and Queens. Queens County is the most diverse county in the entire country. And having the staffing, having the administrative support on my side to meet the needs of every single different type of community in Queens County often is not possible. We have to partner with the physicians in the community. We have to partner with the community-based organizations. And again, that's made possible because of value-based payment. We're all made accountable. We're all financially incentivized to do the best for the individual, to reduce unnecessary utilization, to utilize appropriate community-based organizations for despite everybody's dislike of the language, it is the terminology we use today, social care needs. And it rewards the provider for being responsible for appropriate and effective referrals to these types of organizations. And I'll wrap there, recognizing the time and wanting to leave some time for questions and answers.
Thank you, PK. I really appreciate that. And I also appreciate your humor starting off saying you're from the dark side. I think we all know that there are payers out there that are really purely financial organizations. It's very clear, and you and I haven't worked together, but I've certainly worked with other folks at Fidelis, and I know the leadership team now at Centene Corporate, and it is very refreshing to see the primary objective and the end is to improve people's lives. The means is administering state and federal dollars effectively to do that. So I really appreciate that. You mentioned something else that really resonates, which is value-based payment puts accountability on all sides of the equation. It sounds like it may not be just two sides of an equation. I stopped math a long time ago, but it sounds like there may be, was it Zechariah said quadrangle? Whoever mentioned that, it was a great reference. I'm very curious in terms of all sides of the equation winning. Dr. Aponte alluded to upside risk, downside risk. And to me, it seems like there is a very interesting opportunity with taking as much risk as possible, putting it as close to the front lines as possible. And that has to do with downside risk, especially, and moving towards taking almost full risk. PK, maybe you could start, and I'd love everyone else from the panel to chime in. Is it feasible to have community-based organizations and FQs take downside risk, operationally speaking? Have you seen it done? Are there any tips of how to do it best? What are your thoughts, PK? And then I'd love to hear Dr. Aponte and Zechariah chime in as well.
So I'm going to say something that sounds counterintuitive,
okay,
but I think it's important. Dr. Aponte said, if fee for service, we should kill it. And while I generally agree with that, the reason why we're at that place is because it's been around long enough where we figured out how to abuse it. So when it comes to community-based organizations and the funding structure that needs to be put into place for long-term sustainability, the initial answer has to be, for a short period of time, fee for service. North Carolina put out a fee schedule for social care needs, where there's some general structure around what does a meal cost, what does a transportation, a taxi ride from here to there cost. It's a pretty extensive fee for service list. And in order to create stability at the onset, I believe a fee for service type reimbursement is needed, and then quickly shifted away to some level of payment for value, payment for quality. Those quality measures or just any type of measurement at all doesn't exist yet. I completely agree that we shouldn't have to perpetuate or reiterate analyses that support the benefits of a medically tailored meal. But we need to understand what medical expense, speaking of in lieu of services, what medical expense that eliminates, so that we can have some level of measurement in place to create a sustainable pay for performance, pay for quality infrastructure going forward. At this stage and we're still at the very front end of it, at this stage, I think it would be detrimental to put community-based organizations at risk for services. I think we need to fund them. We need to support them. We need to create a structure that they can thrive in. And then once that maturity exists, then we can begin to have that conversation. Providers are very much in a place where risk is within their capabilities, despite their hesitancy in some places, despite me hearing that they're not built for insurance risk. I am, and I agree to that, I am. But I think we're at a level of maturity with some providers, not all of them, that risk can be bared by the plan and the provider. And we should let community-based organizations, at least initially, create an infrastructure where they can thrive.
Thanks, PK. Zachariah, any thoughts on that?
Yeah, I appreciate that acknowledgement about where the community-based organizations are in doing this work. I also want to say, I think one of the challenges is that the studies that show many of the community-based community resource impact on healthcare savings. The problem is you don't know exactly where that healthcare savings accrues to, how much of it accrues to the healthcare system, how much of it accrues to the plan. And I think that's why people get caught up in having CBOs participate in, because they don't know how much it's going to benefit their plan or their members or their patients. So I think there is the need to understand a little bit better where the value accrues to with community resources. And then the last thing I'll say on this is just that, there is, we have a food and nutrition services bundle. So what it is in response to food insecurity screening, you need a reliable solution, and medically tailored meals is just going to be relevant to, 3 or 4% of people who are food insecure. What do you do about all the rest if you're screening everybody in Medicaid? So our bundle includes things like SNAP and WIC and home delivered, senior meal delivered wheels, Meals on Wheels, and things like that. And what we're able to start to look at is, when you do food insecurity screening, what proportion of people are eligible for what food resource, and then how much does it cost the community-based organization to enroll in that resource. And so in the beginning, while it may be a fee schedule for navigation and specific new services that Medicaid will pay for, in the long run, what we need to do is say, okay, well, for provider and plan X who are managing a pre-diabetic population, for example, what, community resource do we want to build into that value-based arrangement? The meal may cost the same. The community-based organization may always get paid $7 for that meal. But it might be, when it's packaged as part of what's done for the patient on the provider side, it may become more or less valuable. And then in those cases, not necessarily the meal provider, but the IPA or the intermediary organization might then be able to bear upside and downside risk.
That's really interesting, Zachariah. Dr. Aponte, what do you think in particular about that downside risk element? Are you allowed to do it? And is there a palette? Would you want to do it eventually?
Right. So much to unpack that was said. I'm going to try to jump in on a couple of things. First of all, PK, you're not on the dark side. I've worked for a plan as well. I won't mention their name. And I think what people need to understand, first of all, having worked for that, is New York State Department of Health dictates how Medicaid is delivered in this state, not the plans. The plans all have their own little window dressings, but they have all the same requirements as far as what they need to do. And having been on that side, I think admittedly, there's a lot of waste in our field. Some of our providers do things that they should not be doing as far as evidence-based care. And so we have to reel that in, because otherwise the cost will become astronomical. And importantly is that these managed care organizations need to have a dialogue with providers. And I think that's what's been the biggest problem, PK, is that the communication between plans and providers and the discussion as to why are we doing the things that we do? Why is this necessary? Why do I need this data? What does this data help me to obtain to advocate for you and be a partner and not an adversary? So that's just one piece of it that I thought was very important. As far as risk, I think the risk, and I think PK is right, the risk for the provider side, we should be prepared to do that. Some practices are not sophisticated enough to take on risk, but those of us that are, because we've really got our ducks in a row, we want to be in that risk environment. It's just a way of increasing share savings. The CBOs, it's too early for them to take on risk now. I agree with that. We really have to understand what that landscape is going to look like, how we're going to deliver that care, how we're going to pay for housing, how are we going to pay for food? And for Fidelis and Centene, they're taking on risk when you pay for something like housing, right? Because in New York State Medicaid, I could be with Centene today and Health First tomorrow and United the next day. And so if PK and Fidelis and Centene are investing all that money in my housing, which we know is going to have a great return on investment, but it may not accrue to their bottom line. Is that fair to them in terms of making that investment, but then not reap the investment that is sold? So I think that's a piece of that we need to really think about, and we don't want to hold people into a plan unnecessarily, but when you make that kind of investment, then there should be opportunity to return on that investment. And that's the part that we still need to figure out. But I think as far as the risk, the CBO side, I think it's too early for them to take on risk, but from the provider side and FQAC, you asked, are we allowed to? HRSA does not allow us to. That's why I mentioned UVO. They put us in an arena that we can't take on downside risk unless we were able to join. There is an IPA in New York State. There is a bunch of FQACs, but they have years of experience. We're able to get some capital and secure some capital, put in reserve so that they can take on risk because they have some reserve capital in place. But we don't have that kind of reserve capital for us to get in there. We need to rely on a partner like you will.
That's great. Dr. Aponte, thank you so much. We only have 1 minute and 45 seconds left. So what I'll do is I'll wrap up and then hand it over to Lauren. There are still some outstanding questions, and so I really appreciate everyone that submitted questions. Maybe what we can do, and Lauren, I'll defer to you, maybe we can follow up with folks and ping the panelists, see if anyone has initial quick reactions to that. But what I will say is I've learned a lot. I've taken a lot of notes. I thought I knew the space. Clearly, you guys know a whole lot more than I do, so thank you for educating me. I will also say that New York is a very sophisticated market, and yet we still have so much more to go. And I'm excited, my own disclosure as an investor in UVO, but the reason I'm excited about UVO and the movement that is happening in enabling safety net providers to take risk is, what about geographies where there isn't the level of sophistication, where there aren't the Zacharias or the Dr. Apontes or the PKs that are trying to enable that kind of participation from communities and doing the right thing and having everyone on kind of both sides of the equation win. So I am excited about the movement that is starting. I'm excited that Ohio is also taking a lead in the space. We've got a lot more states and territories to go. Thank you all for participating. I really appreciate it. Lauren, any concluding remarks?
Thanks, Doc. I first of all want to thank all of our panelists here today. I think it was a really robust conversation. We got a lot of good questions. I'm going to put my email into the chat. So for any of you who have any follow-ups or who would like more direct connections with any of our panelists, please reach out to me and I'll try to triage things for everybody. I think I'll just sort of reiterate what I started with, which is, this stuff is really complicated. And in that complexity, unfortunately, there's a lot of money to be made. And so I think what we are trying to promote here is the idea is that with Ohio's new system, there's a great opportunity to compel collaboration between sort of the commercial aspects of healthcare in ways that align primarily with the needs of patients. And risk is a pathway to get that done. And there's lots of different types of tools and resources out there. But for all of you, whether you represent a provider organization, an advocacy organization, or a CBO, hopefully this provides you with a little bit more vocabulary to empower what you want out of the system on behalf of the folks that you serve. So thank you again for all of our panelists and joining us today. We'll make sure the recording is available and we'll follow up with you so that you have access to a copy. And again, if there's anything you need, please reach out to me by email at Community Solutions. So thanks all, enjoy the rest of your afternoon, and thank you again to our panelists.
Thank you.